Today, we're going to clear your fundus on an absolute high-yield topic for your exams, aneuploidy screening. In this explainer, we're going to move step by step from the absolute basic concepts all the way up to advanced invasive diagnostics. So, let's dive right in. Here is our clinical funnel for today. We'll quickly cover the basics of aneuploidy, then cast a wide net with first and second trimester screening. After that, we'll filter with non-invasive prenatal testing, confirm with invasive diagnostic procedures, and finally, wrap it all up with a high-yield exam summary. All right, Section 1, let's start with the absolute basics of aneuploidy to lay down a solid conceptual foundation. Conceptually, you've got to remember that aneuploidy is strictly about the number of chromosomes, okay? Not their structure, just the number. A normal diploid cell has 46. Add one extra, making it 47, and that's a trisomy. Take one away, making it 45, and you have a monosomy, simple and straight to the point. Looking at the notes here, check out the normal male karyotype on the right. For any defect in chromosome numbers, your investigation of choice, your IOC, is always going to be karyotyping. Ultrasound is just for gross congenital anomalies, not for counting chromosomes. Now, here is a direct MCQ breakdown for trisomy 21. Remember this split. 95% of Down syndrome cases are due to non-disjunction. This is non-inheritable, but the risk strongly increases with maternal age. Only 4% are due to translocations, which are inheritable, and just 1% from mosaicism. Keep those percentages in mind. Moving down our funnel to Section 2, let's look at first trimester screening. The timing for this is absolutely crucial. It's done exactly between 11 to 13 weeks and 6 days period of gestation, or POG. Put a star mark on this dual test pattern right here. Notice how PAPP-A is decreased for all major trisomies, but look at β-hCG. It is exclusively elevated in Down syndrome. That is a classic exam pattern. Alongside the biochemistry, we also do an ultrasound. You see that small fluid-filled area right behind the fetal neck? That right there is your neutral translucency, or NT. To get a truly accurate NT measurement, strict criteria apply. Normal is less than 3 millimeters. Crucially, the fetal head must be perfectly neutral, neither extended nor flexed, and it has to be measured in the mid-sagittal plane. Also, your crown rump length must be strictly between 45 to 84 millimeters. Don't let the examiner trick you on these numbers. They love to test this. Now onto Section 3, second trimester screening. If the patient presents a bit later, at 16 to 18 weeks, we shift to the triple or quad tests. Here is your golden rule for the exams. In Down syndrome, only hCG and inhibin A are up. Everything else, like AFP and estriol, is down. It's literally that straightforward. Compare these two soft tissue markers for a second. On the left is the simple NT, on the right is a cystic hygroma. Notice the difference? The cystic hygroma has much more fluid, a widespread extent, and visible septa inside. Because of this, it's actually a far superior marker for aneuploidy than a simple NT. Section 4. Let's talk about non-invasive prenatal testing, commonly known as NIPT. Follow this diagnostic flow carefully. We don't just jump in with a needle the moment a screening test is positive. NIPT acts as a highly sensitive secondary filter. If the NIPT is negative, you can safely counsel the mother that there is no need for karyotyping. You've just saved her from an unnecessary invasive procedure. NIPT is a real game changer. We draw maternal blood to find cell-free fetal DNA. And where exactly does it come from? Apoptosis of the syncytial trophoblast. Remember that word, syncytial trophoblast. It can be done starting at exactly 10 weeks POG or later. It boasts a massive 99% sensitivity, but remember, doctors, it is still a screening test. It is not definitively diagnostic, and it can be pretty expensive. Section 5. Invasive diagnostic procedures. What do we do when we need absolute certainty? Let's contrast our two main options here. Conceptually, CVS gives you answers much faster, usually within 48 hours, and earlier in the pregnancy, between 10 to 14 weeks. But amniocentesis, which is done later at 15 to 20 weeks, is significantly safer, carrying a fetal loss rate of less than 0.5% compared to the 1% with CVS. Look at the anatomical approach in these diagrams. On the left, CVS targets the placenta directly to grab those chorionic villi. On the right, amniocentesis safely aspirates about 20 milliliters of fluid directly from the amniotic sac, and this is done entirely under USG guidance to ensure safety. Now pay very close attention to this clinical warning. Never, ever perform a CVS before 10 weeks POG. Why? Because of the high risk of limb and oromandibular defects. Examiners love to test this fact. Also, note that amniocentesis utilizes a fine 20 to 22 gauge spinal needle. And if you need fetal blood directly, cordocentesis from the umbilical vein is done at 18 weeks or later. Finally, Section 6. Let's wrap this up with a high-yield exam summary. Burn this pattern into your memory right now. For any biochemical screening question on Down syndrome, just repeat after me. hCG and inhibin are up, everything else is down. Seriously, this one simple rule is going to instantly solve 90% of your marker MCQs for sure. Here are your rapid-fire facts. Make sure you know these cold. Trisomy 16 is the most common cause of spontaneous abortion, while trisomy 21 is the most viable. What about the most common heart defect in Down syndrome? It's an endocardial cushion defect, followed by VSD and then ASD. And again, remember that fetal loss rate, 1% for CVS, less than 0.5% for amniocentesis. Let's leave off with this provocative clinical scenario. If parents have a balanced translocation, T21/21, what do you think the recurrence risk is for the next child? The answer is an absolute 100%. Every single viable pregnancy will unfortunately have Down syndrome. This is a vital high-stakes point for your genetic counseling cases. Keep studying hard, clear those fundas, and I'll see you doctors in the next explainer.